yes, I will get the eclampsia box, and then goes and does it, then both the person giving them the information and the person receiving it know that they're on the same page. And so it's both the person who's the team leader, but also all the members of the team have a responsibility to feedback and maintain everyone's awareness of what's going on. Next slide, please, Tim. Because effective communication involves making sure that the message is clear, so given in a particular way. So and ideally addressed to a specific individual. So in that emergency, when perhaps there's eclampsia happening, you might gesture to somebody and say, oh, please, Tim, would you mind getting the eclampsia box and bring it right back? Making sure it's understood, and that's where that closed loop communication comes in. Yes, I'll get the eclampsia box and I'll bring it back. We both know we're on the same page. Making sure that it's heard, but done in a calm way so that people can just get on with the emergency. And as soon as you have this kind of shared mental model, that just makes the team work much more effectively. Next slide, please. And this is particularly pertinent right now. We all know that when we're using PPE, face masks, goggles, things like that, it makes communication so much more challenging. We're so used to the visual clues about what a person's face is showing. And so we have to be much more explicit and do the basics even better if we're wearing PPE, making sure that we establish that eye contact so people know that you're looking at them. And remembering that as well as the rest of your team that you're working with that may be struggling to hear and understand what's going on, the woman and her partner as well will be having similar difficulties, and knowing that we're all coming in with this gowns and masks and so forth, which look very scary. So just making sure that there is someone who's tasked with having that focus on the woman as well and reassuring her that everything that's going on and maintaining the communication with the team, but with the woman as well. Next slide, please. Now, I'm not sure whether SBAR is a term that's very familiar to everybody, but it stands for Situation, Background, Assessment, and Recommendations. And this is a communication tool that allows us to give a very rapid handover. So if we say, right, the situation is Mrs. Mohammed has got a blood pressure of 180 over 110 and severe headache, and she's just had an eclamptic fit. The background is, this is her first baby. My assessment, her blood pressure is very high. She's now conscious, but my recommendation is, please will you go and get a senior team, get the eclampsia box and come right back with them. And then of course you're expecting someone to say back to them, yes, I'll get the senior team, I'll bring the eclampsia box and I'll come right back. Next slide. And there's a lovely example of good SBAR type communication that happened on the day where Captain Sully Sullenberger landed that plane on the Hudson River in New York. And we're not trying to train obstetricians and anaesthetists, midwives and nurses into being pilots, but it's worth thinking about picking up some real world examples where communication and team working has worked well. And on that day, as soon as the plane hit these flock of geese and was falling out of the sky, he made an emergency call. He said, Mayday, Mayday, Mayday. This is Cactus 1539, hit birds. We've lost thrust in both engines. We're turning back towards LaGuardia. Next slide. So just thinking about those words, and you can see that they're succinct, they tell the story, and they are structured. SBAR, situation, background, assessment, recommendations. So thinking about doing that as an effective way of handing over. Next slide. And of course, it was a good news story. So it's always a great one to use as an example. But the main thing is that we can use this in our own clinical life, in our own clinical sphere. And within the PROMPT training package, we've got these tools that allow you to be able to structure your handovers, situation, background, assessment, recommendations. And we're showing that that helps teams be much more effective in real life and simulated scenarios. Next slide. But another thing that we thought that another thing that came out of that situation was this great bit of communication within the cockpit. We had a very senior, very experienced captain, and we had a first officer who was his first week flying these planes. And even then, in the midst of this emergency, the captain turns over and says, "You got any ideas? You know, how can we get out of this situation?" Trying to mine the collective intelligence of the room. And unfortunately, the response from his first officer was, "No, actually, I'm out of ideas." But, you know, it's great to be inclusive and make sure that, because, you know, the most important person in the room during any emergency is the patient. And so it's our group responsibility to get as much expertise from around the room and focus it on them. Next slide. And another thing that happened very early on in the emergency was the captain, again, very experienced. He's been a fighter pilot, test pilot, but he said, "Get the quick reference handbook." And this is a little handbook that's in the cockpit. So if there's an emergency, rather than having to remember all the steps that you do in an emergency, it has the steps written out about how to manage it. Next slide. And if we think about what happens in our situation in hospitals, this kind of handbook is something that we have. They're clinical algorithms. They've got the national guidance, the best ways of handling any particular emergency. And so it just makes sense in this time when everyone is very panicked, very distracted, and our memories start to fail, is to be able to pick this up, and any member of the team can pick up, read through. So this is an algorithm for shoulder dystocia, and be able to go through things step by step. Of course, in doing so, that brings out that information for the whole of the room, so everyone can benefit from understanding A, what they should be doing, and B, where they are in the course of this emergency. Next slide. But as well as doing these things for making an efficient team, teams need to have various people. They need to have a leader, and they need to have people who are doing as well. And, you know, great leaders have got certain attributes, so they're focused on the outcome and not on themselves. They're competent, they bring people up. And we can all think about, you know, people in either in our work lives or in our home lives or in our outside of work, who we can look up to, and we think, okay, they're a great role model, and they probably do a lot of these things. Next slide. But also, you know, we all have our own responsibility as well when we're in a team. So we're just going to run this video of some people who have come to help someone who's been injured. And let's see how the team members take on their various roles. So you could say there's a little problem with leadership, but also you've also got to be listening and taking the information on board as well. Next slide. Now, another thing that we talk about a lot when we're dealing with team working is thinking about situational awareness. It's one of these concepts that's sometimes quite difficult to get across, but it's kind of, rather than just seeing what's happening, it's kind of understanding what's happening within the context of a bigger picture. And often, you know, it's often described in terms of a helicopter view. And it's about being able to mentally stand back, or sometimes even physically stand back from the action. So you've got a bit of an overview of what's going on. Because the closer you are, the more task focused you are, the harder it is to understand what is happening within the context of the emergency. So Tim, if you wouldn't mind playing the video. So this is a video of an athlete who has just finished her race. So she's still on a bit of a high, but you've also got someone who's on the long jump and he's just starting his run. So he's very task focused. And unfortunately, this woman gets distracted because someone calls out to her. And yes, but you can see how two people, one person is very task focused, one person very distracted, lose all situational awareness. And yet there would have been about 50,000 people in the stadium who could all see what was about to happen. So in an emergency, it's very natural to get kind of tunnel vision and very focused. We all need to remember to think about mentally or even physically sometimes stepping back to get a bigger picture. Next slide. So it's about taking that broader view and declaring the emergency, making sure we communicate clearly. It's especially important in an emergency. Thinking ahead and prioritizing, okay, what are the next steps? And making sure that we use our team effectively. And that allows us to be ahead of the game. Next slide. Now, Tim's already talked about it's more than just thinking about training, it's thinking about systems and tools that we can use to make sure that we do the right things at the right time, the right way, the easy way. Next slide. It's about having various things that will tell us, okay, how do we manage this emergency safely? How do we document what we've done? And how do we make sure that we provide the best possible care? Next slide. And having those algorithms and so forth within the boxes. So if you are dealing with emergency, people bring the box with the equipment that you need, the drugs that you need, but also the algorithms and the tools that explain how to manage the emergency. So hopefully we've been able to just dip into toes in the water of explaining the training a little bit, making sure that we kind of bring the best of the international and national guidance to the units through tools and devices and training. Remembering that the reasons that we do the training is to make sure that we avoid any avoidable harm. Remembering that, it's the safe maternity care involves lots of people coming together in a coordinated way. And it's more than just a kind of technical intervention. It's very much a social intervention as well, providing the right tools to make the right way the easy way. And remembering that we all have a responsibility to make sure that we think about our team working, our communication, and we'll have an opportunity to think about that a little bit more in our interactive session, which hopefully the internet will work better for. Thank you.
Thank you very much for that, Neil. That was very good. There was one question on team working that is certainly in under-resourced areas from Hussam in Marrakesh. They have quite a high turnover and recruitment. Obviously, can make the teamwork working together as a team a bit more difficult. Have you any thoughts on that?
Yeah, absolutely. I think one of the problems often is that when emergency teams come together, they're having to form an ad hoc unit. So one thing that we think is important is, first of all, to do the training repeatedly. So our model is to do the training once a year, so that as you are getting new people coming in, they're learning the new systems and they're learning the ways that the systems work in your own unit. And I think the other thing is having the tools around. So if you have an algorithm, that helps bring the team together irrespective of whether they've worked together or not, because you can say, okay, this is shoulder dystocia. I've never worked here before. I'm not quite sure how they do things, but here it says we start off with putting the woman in Mac Roberts' position and, kind of take it from there. So I think doing the training, training 100% of the staff, so everyone in the unit knows the system, training regularly, so once a year, so that it gets reinforced and new people come in, know the system, and then using the tools and algorithms.
Great. Thank you very much, Neil. And I'd like to pass it on now to Mohammed Al-Dabi, and he's going to talk to us about eclampsia, another emergency that I'm quite sure you come across. Mohammed.
Thank you so much, Mark, and thanks everyone for having me. It's a pleasure to be talking to both worlds, both Egypt and the UK, and the wider audience. My name is Mohammed, and I'm one of the obstetricians at Southmead Hospital, which is the birthplace for PROMPT, and I'll be talking to you about eclampsia and preeclampsia and severe hypertension. Let me start by sharing my screen. Just bear with me for a second. 1 second. I might stop the video just to make it a bit clearer. That's okay.
Is it working?
Is it working now?
Yeah.
There we go.
Yeah.
So I know this is quite a busy slide, and I won't trouble you too much by all the definitions on it, which I'm sure you already all know. But I just want to point out certain cutoffs that are set by NICE, the National Institute of Clinical Excellence, about the definition of hypertension, which is blood pressure that is equal to or above 140/90, and that of severe hypertension, which is equal to above 160/110. Hypertensive disorders in pregnancy are quite common. In the UK, 10% of all pregnant women will have high blood pressure in pregnancy, 6% will have preeclampsia, and 1 to 2% will have preeclampsia. And actually 10% of all preterm deliveries will be related to hypertensive disorders. The burden of hypertensive disorders is quite significant in both mothers and babies. And potential complications include intracranial hemorrhage, which remains the leading cause of death from preeclampsia in the UK, abruption, coagulopathy, eclampsia, HELLP syndrome, and end organ affection. "209 women have died in association with pregnancy and childbirth between 2015 and 2017. Of those, sadly, 6 deaths were related to hypertensive disorders. Between 1997 and 2017, there has been a significant reduction in maternal mortality due to preeclampsia, but the leading cause of death has remained the same, which is intracranial hemorrhage followed by HELLP syndrome. In the next few slides, we'll be trying to focus on management of hypertensive disorders in pregnancy. And first is the recommendation to use aspirin for reduction of preeclampsia. The national guidance in the UK would recommend that all women be risk assessed for their risks for having preeclampsia, and those with one high risk factor, which is either having a previous history of hypertensive disorder, type 1 or 2 diabetes, chronic hypertension, or those with 2 or more moderate risk factors, like being the first pregnancy, being 40 years or older, having family history of preeclampsia, for those to have aspirin from 12 weeks till delivery. And this has been proven by multiple systematic reviews to reduce the risk of preeclampsia, severe preeclampsia, fetal growth restriction, and more significantly in preterm preeclampsia. The full details of management of hypertensive disorders are beyond the limits of this talk, but I will touch briefly on the main headlines. The focus would always be on controlling the blood pressure, and the choice of antihypertensive is usually labetalol, unless it's contraindicated or not effective. The second choice would be of nifedipine, which is a calcium channel blocker, as I'm sure you all know, and methyl dopa is third line. After that comes the monitoring and follow-up of both mother and baby. An individualized plan regarding frequency of blood pressure monitoring and whether that's at home monitoring or monitoring in hospital. Frequency of serial ultrasounds for growth for baby are all essential. Ultimately, plans should be made for delivery, usually aiming for 37 weeks, unless otherwise indicated, with plans also being made for postnatal care. The definition of severe hypertension is blood pressure over 160/110. And in such cases, the main aim is control of blood pressure. Now, this is one of the examples that Neil has alluded to of having an algorithm and how important that is for everyone to be able to read through the algorithm and follow it in an emergency. The first choice of antihypertensives is usually labetalol, unless women have bronchial asthma or of Afro-Caribbean descent, in which case nifedipine is used. The first dose of labetalol is usually 200 milligrams given orally, and blood pressure is checked after half an hour. If the blood pressure remains high, then a second dose of oral labetalol is given. If the blood pressure continues to be high half an hour after that, then IV labetalol is given, with a loading dose of 40 milligrams over 2 minutes that could be repeated up to 4 times. And then a maintenance fusion is started with a rate that ranges between 4 to 32 mils an hour. Alternatively, if nifedipine is used, a 10 milligram capsule is given orally, not sublingually, and blood pressure is checked in half an hour. If it remains high, a second dose of oral nifedipine is given. And if it continues to be high, then hydralazine, IV hydralazine is started with an initial dose of bolus dose of 5 milligrams over 15 minutes that could be repeated if systolic blood pressure continues to be high. After that, maintenance doses of blood pressure medications are written up. I just want to stop there for a second and ask you to think about where is the best place to look after women who have that condition, severe hypertension, and that is in the context of your local units as well. In our unit, delivery suite tends to have more medical personnel to patient ratio, so patients with severe hypertension are managed usually on delivery suite, despite them not necessarily being in labor. And if they need IV antihypertensives, then potentially will be managed in an HDU setting, high dependency setting. Also worth mentioning, who do you want to be with you when you're managing such a case? Usually on our team, we have an obstetric anaesthetist on site all the time, and they're usually very helpful in managing those cases, along with the midwifery team and the NICU team. I have trained in Egypt, so I'm aware that in some units, the use of magnesium sulfate is much more common than in the UK. But generally speaking, recommendations in the UK would be that magnesium sulfate is used either for primary prophylaxis if we suspect that a woman with hypertensive disorder with preeclampsia, severe preeclampsia, might be at high risk of developing eclampsia, and that's if they are symptomatic, or if they are hyperreflexic, or if they are rapidly deteriorating. It is also used in the context of secondary prophylaxis for those who've actually had an eclamptic fit to prevent further eclamptic fits. And another context of use of magnesium sulfate is for neuroprotection for babies in preterm deliveries, but that is not unique to preeclampsia. As Neil was pointing out in his talk, one important role of a team dynamic is the team leader. And the team leader should be able to step back and have that helicopter view and not get too involved in the tasks that an emergency would involve. So this slide shows sort of trains of thought or concepts that a team leader should be thinking of when managing a case of severe preeclampsia. How would they stabilize a patient, control their blood pressure and give them magnesium sulfate and potentially limit their fluid intake? How would they monitor and where? And I'm not quite sure if you're familiar with the early warning charts that are used in the UK. They are quite an easy tool, again, in the context of easier communication, and we can talk about that a bit later if you have any questions about it. How are they monitoring the other patient, which is the baby? How often are they doing CTGs? How often are they doing bloods? And then ultimately planning for delivery. When should they aim for delivery? Is there an indication for an earlier delivery? And what to do differently in a first stage, including, say, for example, having continuous electronic fetal monitoring? Is there a need for shortening the second stage? And what are the thresholds for offering instrumental delivery if needed? And how do we manage the third stage effectively without putting the woman at risk? You all know that ergometrin would increase blood pressure, and in that context, it's contraindicated. So what other medications are there, like syntocinon? Kathy and Neil will have a video in the next presentation about the management of eclampsia. So I won't dwell too much on this slide, but it's perhaps worth mentioning and pointing out that, as with any other emergency, it's important to have that team dynamic, that effective team dynamic, and the ABCD approach towards any emergency, including eclampsia. As Tim was pointing out, one of the truly added values of PROMPT is how it facilitates training and management of obstetric emergencies and making the right way the easy way. In all obstetric emergencies that PROMPT deals with, there's usually a collection of guidelines, medications, equipment needed to manage an emergency, all collected together in a labeled box. And everyone in the unit usually must know where that box lives. So in an emergency, we can all quickly go to that place and grab that box. This is a picture of our local eclampsia box. And you can see it contains Gadel airways, IV access, blood taking kits and bottles, magnesium sulfate, and you can see down there, it's in different sort of packets. One of them is the loading dose and lots of them are maintenance doses. And on the right is a very simplified guide to how to draw up and give magnesium sulfate that even I can use sometimes. So it says down there that draw up 8 milliliters of 50% magnesium sulfate and 12 mils of saline. Simple as that. Doesn't say that you need to give 4 grams and stops there, but tells you how to do it. In all emergencies, the value of documentation cannot be emphasized enough. It's very important to avoid litigation and also to help with audits and learning. Standardized documentation make it easier for us to document events during an emergency. During each emergency, and one of the team rules is that ideally someone should be documenting the emergency as it unfolds. In this particular eclampsia performer, for example, there are places to record who was there when the eclampsia happened. At what point was the call for help put out, and who responded to that call of help, and when. Also, it has places for documenting the steps that were taken for management and when were they taken. And I think this brings us to the true value to the question of what is PROMPT? Why is it important? Why has it made such a difference? I think all the guidelines, even those used by PROMPT, can be easily accessed online. And I'm sure you know them much better than I do. But PROMPT, through simulation training, gives those guidance live and brings them alive. And you can see that suddenly something simple like call for help has a different meaning. They make the training feel real so that people in an actual emergency will feel more comfortable, act in a calmer and a more efficient manner, and patients will feel safer and outcomes indeed will be better. All emergencies, if you read through the guidance, in all emergencies, the management starts by call for help. And this is going to be one of a few examples that I'm going to give next about how PROMPT gives life to a solid or a guidance. What does call for help mean? What does that translate to in your units? I want you to just take a minute to think about that. How would you call for help? In medical facilities in different parts of the world, there's the emergency buzzer that's outlined here. Where you pull it, there's a certain alarm call that goes off that is universal in the UK, for example. And we all know we all stop what we're doing and head directly to the alarm if that happens. A simple example of how PROMPT may help is to conceptualize what call for help is for your local unit. You might not have this call bell system, but you need a system by which you all agree this is our system for calling for help. This is what we mean. Neil has pointed out that time is critical in emergencies, and by having that trained for by all team members, then that will buy you some time and some minutes that might prove very valuable in the context of an emergency. Also, who do you expect to turn up when you call for help? If you imagine right now, you've got an eclampsia on your ward and you call for help, who do you expect to turn up? And wouldn't you want them to be of variable skills? So you have to have an anaesthetist, to have a midwife, to have someone, a pediatrician, all available on your team to help you with those decision makers and managing those emergencies. And if so, wouldn't you want to train with them so you can all speak the same language and all sing from the same sheet? And in some contexts, if you pull the emergency bell in some units, those are the people that will turn up, a midwife and an anaesthetist, and even the MCAs, the support workers, will be available, and they have an important role in such an emergency. When you train locally in your own units, you familiarize yourself with your equipment. Those images are from our delivery suite from room 7, to be specific. And say, for example, the one on the left is from a bed. Each bed has a CPR handle by which it lies flat instantaneously. In the context of eclampsia, for example, you would like to nurse your patient in a safe position. And if for any reason the back of the bed was up when that happened, if you're not familiar with how to straighten your bed, then you would lose time and wait for someone who is. So training locally gives you that familiarity with your own instruments. In the middle there is our blood pressure and pulse oximeter machine. And again, if you're not familiar about how to use those machines, you're going to lose some valuable time till you find someone who is. You're going to face frustrations, and you might lose some important information that will help guide you with managing an emergency. We are all here to improve our patients' outcomes, and eclampsia, and as with other obstetric emergencies, practice does make perfect. I think the real purpose of my talk was, of course, not to tell you more about the guidance on eclampsia or just that and the management of severe hypertension in pregnancy, because you all know that by heart, and it's there, it's out there, it's on the internet. I think the main value was to stimulate you to try and encourage you to think about how do you see the future? How do you want your future to be? What outcomes do you want for your patients, and how to get there, and how can PROMPT help? I want to conclude by a quote by Benjamin Franklin, and it goes, "Tell me and I forget, teach me and I may remember, involve me and I will learn." Thank you.
Mo, thank you very much for that. Indeed, very comprehensive. It's been quite interesting. We're getting plenty of questions, which is good. I think to say that I'm pretty sure, Professor Salam, I will confirm later, but I think the plan is that there'll be a recording of this webinar as a webcast, and it'll be made available through their college website. So we'll, I'm sure, give information on that. And yes, quite a few questions just on the drugs and stuff being used. And I think what it does identify when we do take our training to other countries, there's a lot of localization required. Maybe it's a lot of the advice and guidance is there, and that's it. But when we look at the different drugs you're using, and there's some questions coming through on that, so there's little nuances that are important, that we put those in place when we do start to train in other countries, just so there's no confusion in what they use. But well done, thank you, Mo. So next we have Neil and Kathy Winter, and they're going to look at our interactive eclampsia drill. There was also a question on looking at training in COVID, and this will be illustrate some of our training we have had to make online. So having people sitting at home watching like you are today, so to try and demonstrate how it's safe to manage in these COVID days. Neil and Kathy, thanks.
Okay, thank you. Now we're going to have a really good attempt at sharing the screen here. I'm going to try it this time, and please tell me if the quality isn't good enough. Okay, so if I share the screen, that one, and share, bear with me. As we say, technology. How's it looking, Neil?
Yeah, no, it's looking good.
Is it pixelated?
So just going to say that, so the idea of this session is to bring you, all the audience there, onto a prompt day. And so we often start our days with some lectures and a bit of an update, just learning the facts. But then it's all about the team having opportunity to practice and rehearse, as Mo was just saying, the management of these emergencies. Now, I've seen there's some questions about how do we do our training during COVID times? And this is one of the things that we have been encouraging units to do, is to, if it's not safe for them to do face-to-face training, is to use these tools, and these are available on our website and also on our YouTube channel, which Tim showed the details of earlier. But if you go to YouTube and just search for PROMPT Maternity Foundation, it will take you to our page and you can find these videos. So over the course of the videos, it's the management of a woman with severe preeclampsia, and there'll be a couple of pauses. And during these pauses, we'll be able to think about a few things. So we'll be able to think about, okay, what about the clinical management? Okay, if I were a member of this team, what are the sorts of things that I would be doing? What would I be calling for? What would the treatment be? And so on and so forth. So we're going to cover some of those clinical bits as we go through.
We're also going to cover the local systems. So we're going to hopefully stimulate you to think about the local systems that you have in place in your unit for managing this type of emergency. Think about how would your team do it in your unit.
And then as we go through, as well as thinking about did they give the right treatment and so forth, also think about how do they behave as a team? Were there things about the communication? Were there things about the leadership and the way people acted within the team? Were there things about the situational awareness and the planning ahead and taking the helicopter view that meant that they either managed this emergency well, or were there some things that they could do better? We'll have an opportunity to reflect on some of those things at the end. So yes, as we said, there will be these pauses during the video, and it's an opportunity for everyone just to think about what would I do in that situation. And what we probably will do is have, if there are particular points that are raised in the Q&A, then Mark and Mo, I think, might shout them out. But I think this is really an opportunity to kind of internalize and think about the way that you manage things currently in your unit and how things might be improved if we did things slightly differently.
Okay, so hopefully the video is going to run. And as Neil says, we're going to pause it every so often and just have a little bit of a discussion about what actions we might do next.
Hello. Welcome to this prompt interactive scenario. In this video, you'll be observing a clinical team managing an obstetric emergency. The key objectives of this session are to provide a refresher of the clinical management of a woman with severe preeclampsia, to discuss the local systems in place in your unit for managing this type of scenario, and to understand how human factors may influence the team's ability to manage the emergency. There will be pauses throughout the video so that your teams can discuss these key elements. You might find, as you work through, that you notice that there are things that the team could have done differently, whether it be clinically or from a human factors point of view. You may have been given a teamwork checklist or a clinical checklist. These will aid a debrief discussion at the end of the scenario.
A 30-year-old woman called Rachel has presented to the obstetric unit believing she may be in labour. This is her first pregnancy and she is 39 weeks pregnant. She has been well throughout her pregnancy, however over the last few days she has noticed increased swelling in her ankles and has abdominal pain and a headache today. Therefore, the midwife has advised Rachel to come into the unit for a review. Her COVID-19 status is unknown.
Hi, Rachel. My name is Jane. I'm the midwife who's going to be looking after you. Tell me what's been happening.
Oh, just feeling really rotten. I've had this awful headache, and I thought it was going to go, and I've just woken up today and it's still there.
Okay, and it's your first baby, is that right?
Yeah.
I'm just going to have a feel of your tummy.
Yeah, that's fine.
Do you know what you're having?
Little girl.
Oh,
I feel really strange and
okay.
just not myself.
Well, let's do a full assessment. Oh, that's beautiful. Let's measure you. Okay. I'm going to put the fetal monitor on to monitor the baby's heartbeat.
It's just horrible, this headache.
And your eyes feel okay?
I feel all right, maybe a bit blurry, but...
Your temperature's okay.
Great.
What I might need you to do at some point is do a urine sample for me. Just check your blood pressure. It's 165 over 110.
So, what should the midwife or the nurse be doing next? So she's got a woman who's got what sounds like, she's got high blood pressure now. She's got some symptoms. What would you be thinking about if this was a woman who presented on your unit? And who else might you want to get involved?
Okay, shall I start again?
Yeah.
Oh, sorry, Mark. Yeah.
I know that. Well, there's a question I think I'll probably ask you at the next pause that's come through. So you carry on.
Okay.
I'm going to press the buzzer and ask my senior midwife to come in.
Hi, Jane.
Oh, Sophie, hi. Rachel, this is Sophie. I'm just going to tell
Rachel.
her.
I'm one of the doctors.
I'm just going to tell her all about you.
Yeah.
So this is Rachel. I think the situation is she's developing preeclampsia. Her background is it's her first baby. She's 39 weeks pregnant. She's had an uncomplicated pregnancy up until now, and then felt really unwell yesterday, didn't you?
Yeah.
And a headache sort of developed, and she's got a little bit of discomfort up here, and her ankles are quite swollen. So the assessment is, I've done an abdominal palpation, and her fundal height is 36 centimetres.
Okay.
Her blood pressure is 165 over 110. I haven't been able to get a urine sample yet. My recommendation is, Sophie, I think if you could do an obstetric review, I'll put a cannula in and do some bloods. Is that
That's
okay?
great. As Jane mentioned, your blood pressure is quite high. I think we're going to need to get that urine sample. Jane, if you could put a cannula in and take some pre-ET bloods, FBC using these LFTs, and we'll take a group and save as well. So we just need to check your blood tests to see if there's any changes on that. This looks like, as Jane mentioned, it might be something called preeclampsia, which is a condition of pregnancy. We just need to manage it with some medication to help lower your blood pressure, and that should make you feel quite a bit better. Do you have any medical conditions or any allergies?
I'm asthmatic.
You're asthmatic?
Yeah.
I'm just going to have a little feel of your tummy. Is any of that sore?
It's just up here, but that wasn't a problem earlier.
I'm just going to test your reflexes. So just going to hit your knee with this little hammer. It shouldn't hurt, okay? Okay, it's a bit brisk.
Okay, so thinking about where you'd find your guidelines or algorithms in your unit, and these will be your guidelines for managing severe preeclampsia. Do you have them on the intranet or internet? Are they electronic? Are they in a folder somewhere? So again, part of the training that we would do in our unit is to make sure everybody knows where the guidelines are. And for us, we'd actually keep our guidance for managing severe preeclampsia in our eclampsia box, because just as Mo mentioned earlier, we would often have women that are severely preeclamptic up on the labour ward, and we would have our emergency box in the room in case anything further happened, but also so that we can refer to the algorithms. Certainly, if you see the next part of the video, you'll see that Sophie actually reads from the algorithm, so she's not left to remember exactly how things should be acted upon. She actually uses the algorithm, and that prompts her with the correct medication and the correct dosage. Was there any other questions, Mark, or shall we carry on?
No, well, there was one clinical question, somebody with severe preeclampsia, but no symptoms, so asymptomatic with proteinuria. Was there any, what would you do? Would you conservatively manage at that time?
I would, being a midwife, I'd ask an obstetrician that one.
Yeah, that's a different question to this video. So let's get on with the video.
Yeah.
Okay, I'll play on.
So Jane, after you've popped that line and taken those bloods, I think according to our management of severe hypertension algorithm, because Rachel's asthmatic, we should start by giving her nifedipine, so a 10 milligram capsule, and then we'll recheck the blood pressure in 30 minutes. Okay. We can give some paracetamol for your headache as well, and we're just going to carry on monitoring your baby at the moment while your blood pressure is quite high. Okay.
So the cannula's in, Sophie, and I've taken the PET bloods.
Brilliant. So that's been 30 minutes now. Rachel, how are you feeling?
I don't feel well at all.
Jane, can we recheck the blood pressure now?
Oh, I feel really weird.
Oh, and your tummy?
A lot worse.
Okay, the monitoring is still fine, but you're not looking very well, Rachel. So I think we'll see what this blood pressure is.
Sophie, it's 162 over 104. So
160 to 104. Okay, so we'll need to give some more nifedipine. And okay, right.
Okay, so obviously this emergency is escalating, and so we've kind of got the diagnosis and is thinking about, okay, we've got 2 people in the room. They're both very competent, very good at what they do, but actually, is that enough? Or do we need to get some extra people? How are we going to call them? How are they, when we get the team together, going to manage it? Are we going to think about letting them know what the emergency is, declaring the emergency, thinking about that kind of communication? So let's see how the team manage.
Pull the emergency bell. And we'll get into left lateral. We've had an eclamptic fit. Jane, can you put this oxygen on for me? Can someone get the emergency box?
take your face mask off for you now.
What's your name, sorry?
Kathy, could you get the eclampsia emergency box?
Yeah, sure.
And can you put out a 2222 call, obstetric emergency, room 1, central delivery suite?
Yeah.
And let me know when you've done that.
Okay,
Thank
and I'll
you.
bring the box.
Okay, so there were some very clear instructions there. Where is your eclampsia emergency box? So thinking in your unit, do you have one, or do you have a trolley perhaps? If you do have an emergency box or trolley, where is it located? Do you train with the rest of the members of your staff so everybody knows? Because that's the key to prompt training, is that we will practice so that we know exactly where our equipment is, and that if we bring that equipment into the room, it'll have the things in it that we need to manage the emergency. So it'll have the algorithm, and it'll have all the immediate medication that we require to treat the immediate emergency. So it takes away the fear. It means that everybody that comes into the room stays in the room because they have all of the equipment actually in the box. And if you do have an emergency box, another reason for the training is being familiar with what's in it. So again, that's another thing you can do in your unit. If you don't have a box, introduce one. Or maybe the other idea is that if you do have one, just make sure everybody knows what's in it, and maybe you'll get suggestions from your other staff as to extra things to keep in it, or actually things to take out, more likely. Have a look at what they do next when they get the box coming in. Particularly notice that it's actually me coming back in the room. But if you actually notice, when I come back in the room, I do report to Sophie that I've brought the box in, just for that closed loop communication that Neil was mentioning earlier.
Okay, so airway, that's fine, breathing, good. Can you, if you wouldn't mind just checking the sats.
That's okay.
Do you want me to get IV access?
Yeah, so that would be great. We've got one cannula in. If we get a second cannula in, that'd be great.
Hi, Sophie. I bought the emergency box.
Great. Kathy's got the emergency box. Jane, would you be able to sort out the magnesium sulfate with Kathy? We need to give 4 grams IV in 16 mils of normal saline. I'll just prescribe it. Hi, Tim. Hi. We've had an eclamptic fit. This is Rachel. Her background is she's 39 weeks pregnant. She's a primate, otherwise fit and well. Came in today with a headache, visual disturbance, epigastric pain. We haven't got a urine sample yet, but blood pressure was 165, 110 when she came in. We gave some a 10 milligram nifedipine and it didn't come down, and then she fitted for about 30 seconds at 11:31. It's self-terminating. So we're giving a loading dose of magnesium sulfate now. Neil's inserting a second line, and otherwise CTG is normal and OBS are normal now.
So Rachel, I'm just a senior doctor. We're going to check on a few things and let's look after you. Can I have the eclampsia algorithm?
Yes.
Let's start with that, shall we? Right. So let's. Can I just quickly check a few things, everyone? Left lateral for Rachel. Yep. High flow oxygen.
Yes.
That's one. And we've got a second cannula, and we're doing some bloods now, Neil. Yep. So just taking some bloods. And Jane, we've got 4 grams IV magnesium sulfate.
Doing that now.
Great. And Kathy, you're doing the.
I'm writing down.
She's documenting.
That's great. 168 over 112. Still pretty hypertensive. So let's. I don't think, Neil, we can rely on oral nifedipine. So let's go for IV hydralazine. So if you could get 5 milligrams of IV hydralazine, and we go for the 15 minutes approach.
Yes, that's fine. I'll sort that out with Kathy.
That's great. Thanks, Sophie.
Okay.
So Rachel, your blood pressure, we're just going to need a little more treatment. We've given you something to stop you having another fit. Your baby looks absolutely fine. You're going to be absolutely fine. I'm just going to make a plan with the whole team about where we're up to. Magnesium sulfate's in after eclampsia. We've got a plan for the hypertension. We need to pop a catheter in, Sophie, at some stage.
Yeah.
Neil, anything else you think we could do?
Should we restrict fluids as well?
Let's restrict fluids.
So
that's definitely
on the
sensible.
severe preeclampsia algorithm, we restrict fluids to 1 ml per kilo per hour.
Yeah. So we're just going to get a few things ready, and let's make a decision about how we're going to have this baby in about 15 minutes. Okay?
Okay, so if you were on a normal prompt day when we're face to face, then the team who'd just been involved in that emergency scenario, we'd go through a bit of a feedback discussion with them. We'd ask them how they felt it went. We'd get them to pick out the things that they did really well, because the team did brilliantly. But of course, there are always things that, if they were to do this scenario again or had a similar woman arrive on their unit, they might want to think about doing slightly differently. And then, so this is an opportunity for the team to reflect, to think about their own practice. And what we always try and do is, at the start of the video, we talked about these checklists. And in our training, we have people observing, and it's people who are part of our own clinical team as well. So it's not like kind of external experts coming. We're all kind of in the training together. We'll go through, what do they do clinically? And I think it's very common, and I've seen from lots of the chat, that people will be thinking about very concentrating on all those clinical things. Always remember that in any emergency, if we have a system where there's an algorithm, those algorithms will make sure that the clinical stuff almost takes care of itself. However, one thing that is really transferable between any emergency, be it preeclampsia, eclampsia, be it hemorrhage, be it shoulder dystocia, is the way that we manage ourselves as a team. Do we communicate well? What's our situational awareness like? Did someone take charge? And so just at the end of the video, there's going to be a couple of things where the team either did pretty well or not so well in terms of the team working. And just remembering that those things are the things that are really transferable, and probably the things that we should be concentrating as much, or if not more, than the clinical stuff.
Neil, anything else you think we could do?
Should we restrict fluids as well?
Let's restrict fluids. That's definitely
on the
sensible.
severe preeclampsia algorithm, we restrict fluids to 1 ml per kilo per hour.
Yeah.
situation is she's developing preeclampsia. Her background is it's her first baby. She's 39 weeks pregnant. The assessment is I've done an abdominal palpation and her fundal height is 36 centimetres.
Okay.
Her blood pressure is 165 over 110. My recommendation is, Sophie, I think if you could do an obstetric review, I'll put a cannula in and do some bloods. Is that okay?
That's great. Call the emergency bell. We've had an eclamptic fit. Jane, can you put this oxygen on me? Can someone get the emergency box?
Take your face mask.
Kathy,
Yeah.
could you get the eclampsia emergency box?
Yeah.
If we get a second cannula in, that'd be great.
Hi, Sophie. I bought the eclampsia box.
Great. Kathy's got the emergency box.
I feel, can I have the eclampsia algorithm? Let's just kind of work through that and then see where we're up to.
Okay. Any comments, Mark? Or shall we move on?
Yeah, I mean, thank you very much, Kathy. It's certainly a lot on the chat this time, just about calling for help. They seem to get that. I like the code pink, but quite call code pink, which is quite suitable.
Yeah.
And as I say, a lot of discussion just in different drugs, but it's a bit more of a clinical question, as Tim says, rather than necessarily looking at how we interact and manage them. That's very good. Thank you for that. And if you want to stop sharing your screen, or are you showing the next bit, Kathy?
I am, but I'll stop that to swap over, I think.
Yeah, so next up we're looking at, I mean, obviously iconic almost, but there's certainly been some mention of shoulder dystocia, people that have done shoulder dystocia training, some of it I think in Dubai with this, and one unit said it's not helped them hugely, but others have said it's done very well. So do you want to take that away, Tim and Kathy?
Yeah, I think it's me. Is it? I'll share. Yeah, am I sharing?
So I think the key to the question, so why does it work some places, not others? I think you've got to do the right shoulder dystocia training, and I think that's really, really key. So we're going to talk about that now. Kathy's going to kick us off.
Okay, can you see that okay?
Perfect.
Yeah, fine. So I shall kick off. Tim might do a bit of a double act is what I'd say. Okay, so we're going to have a few slides. We're just going to talk about the problem. We talk about the algorithm that we use to guide our training, and also in real life to manage the emergency. And then we're going to show a short video, and it's another video that's on our YouTube channel. So if for some reason it doesn't play, you can always find it on the YouTube channel as well. So thinking of the problem of shoulder dystocia, most commonly it's caused by the baby's anterior shoulder impacting up against the symphysis pubis of the mother's pelvis. The statistics say that it affects about 0.1% to 3% of all births, but it's probably nearer the 3% mark. Certainly, you need to recognise the problem, and then it needs to be managed efficiently to reduce the risk of neonatal hypoxia and reduce the possibility of a neonatal injury. There are some risk factors. Certainly, previous shoulder dystocia is probably one of our most useful risk factors, you might say. So certainly somebody who's had shoulder dystocia before is more likely to have it subsequent times. Certainly with big babies, and we don't just mean big babies, we mean those babies that are macrosomic, particularly the babies that are of mothers that are insulin diabetics, where you get that baby that's not just a big baby, but it's quite a sturdy baby with the steroid effect. insulin. Mothers, obviously, with diabetes leading on to that macrosomic baby, obesity, and certainly that's a problem in the UK, that we do have increasingly larger women that are pregnant, and again it seems to be associated with a higher risk factor of shoulder dystocia. Certainly when you get into labour, maybe risk factors start to flag up when you have a long first stage, and then certainly when you have that prolonged second stage, where as mum's pushing, you're getting some sort of effect of the head coming forward, but then retracting right back again, might start to alert you that there could be a problem. It seems to be higher risk of shoulder dystocia in labours that are augmented, and also a higher risk in those operative vaginal births as well. So essentially, we've got some risk factors there, both that we might recognise antenatally and that occur during labour. But essentially, we'd say that it's largely unpredictable. We know there's higher risks, but we don't definitely know which woman is going to have shoulder dystocia. And therefore, we'd say that it's unpreventable. So the only real way to manage it is to train everybody to know what to do when it happens. Because even with your best risk assessment, it may be that you're still in a situation where perhaps you have no obstetricians easily. If you're in a birth centre, you might be at home. We do still have home births in the UK as well. But certainly the guidance would be that you train all staff how to manage it, so that when it occurs, wherever you are, everybody knows what to do. One of the complications we're trying to avoid is a brachial plexus injury. And this is said to affect about 2.3 to 16% of shoulder dystocia births, so births where there has been shoulder dystocia. And a permanent brachial plexus injury would be with 3 per 10,000 births in the UK. And a permanent brachial plexus injury is obviously an injury for life. There is surgery that can be done, but sometimes the surgery still isn't successful and you're left with perhaps a person who can't move their arm at all. So if we can avoid that lifelong injury, it seems a good thing that we should try that. There are other injuries like neonatal fractures that obviously they will heal in time, but if you can avoid them, that's better without a doubt. And then more serious things like hypoxia and stillbirth as the emergency progresses, and perhaps if you're taking longer to solve the problem. There can be maternal trauma as well, more higher incidence of PPH and also third-degree tears. Thinking of brachial plexus injuries, of course, we're talking about our PROMPT training, and as Tim mentioned in his introductory talk, you know, it does seem that it's possible with training to actually reduce the incidence of that injury. And as he said, in the first 4 years after our training, we managed to reduce the injuries by about 70%. And 12 years on from that, we actually got our permanent brachial plexus injury rate down to 0. And I'm pleased to say that that continues. And so here we are 5 years later, still with no incidence of permanent brachial plexus injury in our unit. And we've continued with the training, and we train year on year, and we train all of our staff together to manage it. So if we're thinking about how we recognize warning signs, as I've said before, you know, maybe actually in the second stage of labour, you've got that turtleneck, as we call it, where the head's coming out and it's retracting back in again because the shoulders are caught up. You may find that you've got that slow delivery of the face and the chin, and they're slowly emerging, but then the chin is hard up against the perineum. The anterior shoulder then fails to deliver if you try some routine, we sometimes call it diagnostic traction. So we've got the signs that the head is right up against the perineum, we wait for the next contraction, we don't see any sign of the neck or the shoulder, and as I say, we would try some very gentle routine diagnostic traction, and that would be in an axial direction. And if we see no sign of the shoulder, then we would stop and we would declare that this is a shoulder dystocia. When we're thinking of our algorithm, this is the ERC-RCOG algorithm, and this is a step-by-step approach to managing it. It's identifying that you've got a problem and then calling for your help, and then simple maneuvers that we will manage to resolve the problem. You'll see in the video that we're going to show now that Tim and I are running a workshop. So this is very similar to how we run our training sessions. We do drills, but we also run workshops where we just do a step-by-step approach of each of the maneuvers. And we ask all the staff to practice those maneuvers during the training, so that if they've practiced it in simulation, then they'll remember that in the real event. Okay, so here's our video.
Delighted to be here today to talk about the PROMPT shoulder dystocia training. Kathy, one of our research midwives, and I are going to go through the maneuvers today. So to try and illustrate for you how best to manage shoulder dystocia, condition we all know is unpreventable, therefore we just need to be able to manage it as best we can. So Kathy, I wonder if we could get straight on with the maneuvers. One of the things about shoulder dystocia I always think is it's a bony problem. And I always use the analogy of it's like a truck going through a low bridge. So can you imagine the cab of the truck gets through the bridge, but the back of the truck bangs up against the bridge. So can you see the cab is like the baby's head, and can you see the shoulder is stuck behind the pubic symphysis? So it's a bony problem. Just pulling the cab through the bridge is going to damage either the truck or the bridge. So the first thing, Kathy, I wonder if we could try is diagnostic traction. So the key issue here is you need to know there's an impaction. And it's really important, just as Kathy's doing, to pull in the direction of the spine, axial traction. Now, I think when we were young, people definitely used to pull right down. They used to crouch down to try and pull the truck underneath the bridge. But we know now that that's more damaging. So just see, is it coming, yes or no? Okay. The first thing then to do is call for help. You need the team around you. You're going to need a person for each leg from Roberts, and we're definitely going to need someone to do suprapubic pressure as well as the person looking after the baby's head. Now, first thing, call for help. Second thing, let's do McRoberts. So McRoberts, if you can imagine the bridge is tilted slightly forward, then making the bridge vertical makes the arch higher. The woman's the same size, but it just helps you get the shoulders, the truck through the bridge. So Kathy.
So I've pulled mum down the bed.
Yep.
Okay, and then I'm going to make her flat, and then I'm going to take her legs right back so her thighs are against her abdomen, and that lifts the bottom of the bed. Okay, and I'll need somebody both sides so that we're both supporting the legs.
So once the bottom's off the bed, just as Kathy said, then I think that shows you've got McRoberts in the right position. The second thing is, if you do suprapubic pressure, that presses down on the anterior shoulder. That's it, perfectly. And I think like a CPR position. And can you imagine, you need to push down on the truck, not the bridge. So Kathy's now pushing down and across to get the shoulders slightly in the oblique, so down and in the oblique if you can. So if that is unsuccessful, we need to move to internal maneuvers. Just to give you an illustration, again, using the truck and bridge analogy, can you imagine the bridge is like a heart shape? If you could rotate the shoulders into the 2 o'clock or 10 o'clock, you've got more space to run through the bridge. However, if you can deliver the posterior arm, that's like taking the wheels off the truck, drops it down 10%, and you can run it through the bridge. So Kathy, I wonder if we could kind of attempt those two things.
So if I'm going to do an internal maneuver, I need to put my hand scrunched up. We call it the Pringle maneuver. So that's as if you were getting the last Pringle out of the carton. And I'm putting my whole hand in at the base. So at 6 o'clock, not leaving my thumb out. I'm putting the whole hand in with the aim that I'm going to find the posterior arm. Babies often come down the birth canal like pharaohs. And so you can grasp that posterior arm and just deliver it straight up, just like you were putting your arm up in class. The idea of that is that the baby's now one arm's width narrower, and so that anterior shoulder should drop underneath the pubic arch and you can deliver the baby. Any traction I do would be in an axial direction, so never downwards, but axial as if you're pulling along. And in this instance, we would deliver the baby.
Great.
So let's say that delivers a baby for this one, but some babies, the arm is straight and you can't deliver the posterior arm very easily. I always think, going back to the analogy, imagine the bridge is like a heart shape. Then can you imagine if you could rotate the back of the truck to either 10 o'clock or 2 o'clock, there's more room than there is at 12 o'clock.
Okay, so this time I'm putting my whole hand in again, and I put my hand in at the bottom. And this time I can't feel a posterior arm, and therefore all I can feel is the shoulders. So I'm going to aim to rotate the shoulders. So I will push on the front of the bottom shoulder, and I'll ask an assistant to do suprapubic pressure towards that wall. So as we do that, we're rotating those shoulders into the oblique, and the shoulder is released and comes under the pubic arch.
And it still may be worth trying some diagnostic traction to make sure that's released. Now, those maneuvers in themselves seem to be effective. Certainly in the last series we published, 17,500 consecutive vaginal births, no further maneuvers were required. And I think it's important we do the maneuvers that we know as well as we can do.
This is the ERC-RCOG algorithm, which lists all of the maneuvers that we've just demonstrated here now. You can see that you take step-by-step approach to the maneuvers. If you get to the bottom and you've found that they haven't worked, it recommends you go back to the start and start with the McRoberts maneuver again. So take the legs out and put them back in. It may be appropriate if the mother's mobile to put her into all fours position, because just the movement into all fours may be helpful at releasing the shoulders. We also have documentation, and this is the ERC-RCOG pro forma for documenting each maneuver so that it's very clear after the event what actions were taken.
If you'd like to learn more.
Okay, so we're nearly there. Just really, this slide was just reiterating that bit about McRoberts, and I just wanted to show you, because you can't actually see it very easily in the video with the mannequin, but if I just show you there, McRoberts is about lifting the buttocks off the bed. It's not the same as lithotomy. It's way more hyperflexed legs, thighs on the abdomen, knees to chin, but it's just a good example that you know you've done it well when the bottoms are lifted off the bed. And as we said, if you've done all the maneuvers and then they're not working, go back to the start again and take the legs out of McRoberts and back in again, because just that movement might make the difference. We mentioned documentation, and again, it's about writing exactly what you did. So the key thing is, you know, which direction the baby's head was in, which direction you did your suprapubic pressure in, etc. And as I say, the key thing we're doing is trying to avoid excessive traction. Any traction we do is gentle in an axial direction. And if we can avoid that excessive traction, we can avoid those brachial plexus injuries, which can be lifelong. So shoulder dystocia is an increasing problem, but brachial plexus injury need not be. And the most effective training should be made available to all multi-professional maternity teams so that we can manage this emergency as a team together. The ERC-RCOG guideline is the green top guideline, and that will have the algorithm that we used within that guideline. And as we've said quite a few times now, we've got a PROMPT Maternity Foundation YouTube channel, and all of those videos that we've shown today are on that YouTube channel. Thank you. Anything to say, Tim?
Thank you very much. No, I think the key thing here is, I think it's really important to take a phased approach, a structured approach, and to practice the maneuvers on a model. It's very difficult to practice during the emergency. That's the whole point of these things. So look, thank you very much. Thank you, Mark.
Yeah, no, will you stop sharing now, Kathy?
Yep. How's that?
That's great. No, thank you very much, PROMPT team, for your hard work this evening. I hope everybody enjoyed it. We thought we'd have a small, short, moderated session now, just to, I think, obviously, Prof. El Nouri and Dr. Benjamin and Sheriff Abdel Fattah, we're going to join in a chat on how we might, how it might affect the rollout or the the delivery of this sort of training within it. We've seen through the chat today and some of the questions that obviously there are resource issues in various areas. So I thought we'd maybe start this session asking Professor El Nouri, I mean, obviously you'd experience, and Dr. Benjamin, how you feel, what the barriers might be to rolling this out and the challenges would be for people. I think you're on mute.
Yeah. I think this is really very, very important. I think we need the culture of simulation and training in the hostels. So people really should be aware of the teamwork and how to be prepared. And so I think the PROMPT really is a very good example that should be adopted, would be ideally adopted in different hostels. And I think this would be great really to start this in Egypt. I'm aware that some of the hostels are doing it, but it has to be really on a larger scale in different types of hospitals.
And Dr. Benjamin?
Yes, really, thank you very much for this very interesting and wonderful meeting. Actually, for this, what I'm just always worried about how to adapt the local adaptation of the protocols for our protocols in Egypt. Because sometimes there is some differences in treatment, like in the management of severe preeclampsia, we may be more aggressive, putting Maxalf at the first priority and things like that. There is some barriers, some drugs are not available there, like hydralazine, it's not available IV. So how we can adapt the protocol, the guidelines, the algorithms for our protocols in Egypt.
Yeah, I mean, I think that's right. I mean, I think management is, differs with the drugs, but generally what's the right thing to do would happen. I know, Sharif, you've got your hand up there. Obviously, Sharif, you're working in Bristol where it started, but a lot of experience from back in Egypt. What would your opinion be?
Yes, absolutely. And the differences in what's available medications wise is not only between Egypt and UK, but also within Europe. There are differences, and the US, again, they have very different protocols. I think the message I hope everyone is getting is that, which is actually what the very first question we received today, someone commented about expenses and finances. And I hope after this day, after this couple of hours, people notice that there is not a single expensive equipment that was used or mentioned, nothing very fancy at all. It's all organizational changes. So whichever medication is available, whether it's labetalol or nifedipine or hydralazine or something else, this is not the point. The point is organizational, team working, and the boxes, making things available. We have to remember that problems happen or outcomes can be bad with all good intentions and people trying their best to achieve the best outcome. It just, the organizational thing does not help. So just the simple thing like having a box for preeclampsia, so just one box contains all the medications you need. You can get it in 10 seconds instead of wasting 10 minutes going around in circles, opening different cupboards and drawers to find things. And the team working. And again, a big difference I can tell is how calm you should be when managing an emergency, because when people start to panic and shout, this does not really help. It does not improve the outcome, just makes everyone very tense and working under too much pressure. Being calm and being organized and each one knowing their role, this is really what makes the difference.
Yeah, I mean, I'd agree with that, and that's exactly what we saw when we were right before. I'm sure Professor El Nouri will admit it. The first day one of training, all the professors were there saying that we do all the work, and then they realized that in fact, yeah, the nurses helped in the blood pressure, and the next day everybody came and were training together. And I think that's the real message we have, because if people are helping you do things, it takes away some of the panic and the chaos that happens. And that in reality, that is what has happened. But therefore, it's just getting people to accept and change some of their ways to actually work and train with them. Dr. El Nouri, Professor El Nouri, have you seen any changes over the last 10 years since you were last here? Or?
Yeah, I think there is some of the hospitals actually they are using the boxes for the postpartum hemorrhage and for the preeclampsia, and so this is really there is a lot of change in Egypt in the management of emergency obstetric emergency. I think part of it is coming also from the initiated by the PROMPT. I have to admit, you know, when you came and with Tim. I think it was in 2010, as far as I remember. Yeah.
Very nice. Neil, did you want to say something?
Yeah. Thank you. I just wanted to add one thing about the differences in different places, and I think, as Dr. Sharif is saying, it's about localizing it to your own unit and your own practices based on the national guidelines. And so ours is based on ours. In your hospitals will be based on yours, whichever country that you're in. And the other thing is, as soon as you start talking to people about training which involves simulation, again, there's this fear that, oh, that's expensive, that's mannequins and so forth, whereas the majority of the simulation we do is very low tech. We just do it in our units, we use patient actors, and we use the equipment that we have. I think the exception probably would be, and you know, the obstetricians will correct me if I'm wrong, but things like the shoulder dystocia mannequin, to get the fidelity so you can practice maneuvers properly, would be the slight exception, but virtually everything else could all be done without spending a lot of money. The main cost and the main resource implication is freeing up all the staff so they can attend the training.
If I can add something, again, it's one cultural difference is who's leading the managing the emergency. And again, there is always the impression that the consultant or the senior obstetrician must be the one who's leading. But this is, of course, not true, because a senior midwife can have a better view. And when we are the senior obstetrician called in for an emergency, the first person I look for is the anesthetist, because I can manage some aspects, but the anesthetist will manage the more important aspect. I look at the SHO, because the SHO will be able to take the bloods quickly and know which blood samples need to be sent and how to send them. It's just the concept of the teamwork, and not everyone standing back looking at the consultant waiting for the instructions from the consultant. The consultant cannot do everything and they cannot remember everything, and the SHO will have better views that the consultants cannot think of, and the midwife definitely, and how to organize, how to call the porter quickly to get a blood sample. So it's again the sort of superhero culture is not really helpful in emergencies.
Yes, yes, you're right. It's the really simple things. It's, as Professor Drake and myself get a bit older, we struggle to remember long, complicated equations. So therefore, having a little bit of paper shoved in front of us that tells exactly what to do is perfect. And that's something we've noticed makes a huge difference, and it saves that trying to remember when things are not in a good situation. So it's been really helpful. Listen, I'm aware that we are about to, Professor Salama, we're at 8 o'clock. Is it going to shut down at that point?
Again, just to say, there are lots of questions about access to the talks and to the videos, and as it was repeated several times, they're all available on the YouTube and on the PROMPT website, and they are free. So please just spend some time browsing, and you will easily find all this information that was discussed today.
We can allow for a few more minutes if there are important questions to answer, I guess.
I mean, I think we'd address most of the themes. Certainly, promptmaternity.org. If you search that, you should be able to find the website where all the information is on it. I also mentioned as well that some of the videos are created for our e-learning package, and because in COVID we've been unable to perform face-to-face training, and there is an e-learning package which would need some localization, but units are able to contact us and fill in an application form, and they can get access to download some of the material that's on it as well. We're very happy to provide that. I mean, I think it's Friday evening for us, and it's been a long week, and I think we've been through all the stuff. We're delighted to do it. I'd like to thank the PROMPT team very much for presenting tonight, And I'd like to thank you all for inviting us to give the talk. And I look very much forward to communicating further in the future. And if not actually physically being there, but more interactive training and developing the package locally for Egypt and the whole area.
Absolutely.
Thank you very much.
Thank you.
Thank you.
It's been a privilege.
Thank you very much.
Thank
May
you for
I
having us.
join in and ask, and thank you very much for thank the PROMPT team and all the speakers. It was a great pleasure. And we hope to have you in person in Egypt. And I can see people joining from Peru and Tanzania and Saudi Arabia and different other places. And I'm sure all of them will be jealous now, and they will be wanting to have the real training once the pandemic is over, hopefully. Yeah. And thank you again very much.
Thank you. Thank you very much.
Thank you. Dr. Amri, the last word is for you.
Pardon?
The last word is for your good self and for Professor Jacob.
Right. I really would like to thank all the team of PROMPT, Professor Tim Jacob, Dr. Kathy, Dr. Mark, Dr. Wafa, and also Mr. Neil and Dr. Muhammad Al-Hudayb, Dr. Sharif Abdel Fattah, and of course Dr. Hassan Salam. It has been really a great pleasure having this. And I want to say also that I attended a meeting yesterday for the Egyptian societies, including the Egyptian Society of Obstetric and Gynecology, and there is a political will to have a national guideline, only one national guideline from one body in cooperating with other societies. So I think we can incorporate the PROMPT and in these national guidelines. Hopefully. Yeah. Thank you, Professor Salam.
Thank you. Professor Jacob.
Professor Salam, thank you very much. And it's been a privilege, as I said, for all of us to contribute. And I think let's work together to make care best for women right across the world. And I think Egypt leading the way. Thank you very much.
Thank you very much. And then again, until we meet on another pleasant occasion, thank you all. And I think we go back to our daily routine. And thank you, and see you again very soon. All the best.
Thank you. Thank you. Take care. Bye.
Thank you for global.
Next time it will be on Netflix series, so hopefully.
That was marvelous, I thought. Marvelous.
Very well received. I think the comments are all very, very positive.
Yeah, no, I hope it went well, and thank you again.
Yeah, absolutely. Thank you.
Perfect.
Perfect.
Thank you. Thank you, everyone.
Cheers, everyone. See you soon.
Bye bye. Thank
Egypt.
you.
Bye.
Bye.
Okay, good night, everybody. Night. Night, Mark, Sharif, Neil, Cassie.
Thank you, Sharif, again and again.
It's a pleasure. We need to keep doing this again. We need to think of other webinars.
Yes, great.
Excellent. We need to do it now in real.
Yes, of course, and thank you very much.
Alhamdulillah, كله تمام.
Inshallah, I think everybody's out now. Yeah. ان شاء الله نتقابل في يعني الكورونا دي تروح. وميرسي يا دكتور شريف قوي ان انت يعني بتنظم معانا حاجات جميله، كتر خيرك يعني.
والله احنا يعني نتمنى يعني دايما ان احنا نعمل حاجات كويسه. هو الحمد لله من حظنا ان الناس دي حبايبنا يعني، والناس اللي بنشتغل معاهم، فيعني وهم فيري ويلنج الحقيقه. وبعدين الحقيقه كل حاجه افيلبل فور فري يعني، هي مش حكايه ان هم بيستفيدوا منها ماديا في حاجه، بالعكس يعني.
You know دكتور رشيد ان هم في وقت يعني في 2020 في وقت الكورونا حطوا كل الماتيريالز including the PowerPoint presentations على الويب سايت بتاع الرويال كولج for free.
كانوا عايزين الناس تريجستر وتاخدها فور فري.
والالجوريزم and everything يعني.
بالظبط.
مش بس يعني يوتيوب شانل يعني، كل الماتيريالز موجوده.
الرساله وصلت يعني ان الموضوع ما فيهوش اي حاجه